Well, hello. Good morning, Ben Wortham.
Hi, Bree.
Hi. Good to hear from you. Hey, I wanted to give you a quick call. I was thinking about the work that we've been doing together. Gosh, I don't know for how long now. I think we're at about a year of the collaboration between Catholic Charities USA and Nurse Disrupted. Does that seem about right?
That's about right.
Yeah,
Couple
amazing.
years.
I wanted to ask a little bit more. Some of the conversations we've had is about this really sophisticated population health strategy that you've laid out for us at Nurse Disrupted. The intersections of housing instability and access to health care. And you say it so much better than I do. I wonder, can you can you talk a little bit about that overarching strategy you have in regards to that population health and connecting people with resources and what you're trying to achieve with that.
Yeah, absolutely. I think um, just meeting Nurse you all and finding the and discovering the mission of Nurse Disrupted, I think it aligned perfectly with what we're trying to do at Catholic Charities USA, at Catholic Charities around the country. And a part of that is bringing healthcare and housing to the vulnerable population. So we obviously know we have health disparities in this country, and we also have 650,000 homeless individuals. So, in a nutshell, I think what we're doing isn't working as well as we want it to currently, and how can we switch that? And I think figuring out creative ways to bring healthcare, behavioral health services, housing to vulnerable populations is really, I think, how we want to create models and flip the script in how it's going. I think building in Nurse Disrupted. So we're building housing and creating housing in 5 cities across America right now in the Healthy
Yeah,
Housing Initiative. And part of housing chronically homeless individuals isn't just housing individuals and calling it good. We want to
right,
bring healthcare and social services to those buildings and really provide intensive services. Many of these individuals, as we know, the a little over 500 individuals we've been able to house through this initiative over the last 4 years haven't had healthcare and access to healthcare in what? Sometimes 1, 2, 5, 20 years potentially. And
right,
so this combination of our case managers at Catholic Charities being able to provide um, social services and connection to social services and help there in combination with, hey, Nurse Disrupted, our cities and our agencies in Las Vegas and St. Louis have been
right.
using Nurse Disrupted really effectively to say, hey, before you go to the emergency room, or hey, you seem sick today, let's check in with the nurse to see what's going on. And it's been really effective, and it has fit the larger strategy of what we're trying to do when we partner with someone like Nurse Disrupted or the local hospital to not just partner with them for the service and the access to healthcare, but also as step two, figure out a way to share data to make the point that, hey, when we help these vulnerable populations in the right way, we're not only helping health outcomes, but there's also a cost saving aspect involved in it. And so working together with you all has been really amazing to as sort of leverage for the hospital, the data you all have provided to us in sort of overall estimations of cost savings that the nurse disrupted intervention has provided.
Yeah, hasn't the data been incredible? I think one of the things that blows my mind is the return on investment in providing just a little bit of healthcare to people experiencing homelessness. It's just massive. You
Yeah,
know, we don't have to serve, although we do. And I mean, Las Vegas is just an enormous shelter that you have. We have our own personal reasons why we do things. I think homelessness is solvable in a rich country, but we must get everyone to move in a common direction. And you and I talk about this, we can typically get people to agree on money, right? you might
yeah,
not you might not feel the same way I feel about homelessness. However, when we talk about the cost to a community and to society and the cost that you can contain, then we can get everyone to say, oh, this is a very good idea. With the data and cost savings, has that, I know we talk about these reports, we see this, has it helped with the expansion of the program, or with the way that you've been positioning housing as healthcare, and the different whys that need to be there?
Yeah, I think it fits in perfectly. On just like a basic level, the data, we've used some of the data to apply, the local agency has to apply for other grants in their area. But it's also one of those things where we just hired an evaluator, Delaware State University, to do a robust evaluation on the program. And this data and ROI that Nurse Disrupted has provided us is going directly into that evaluation that's hopefully going to hit the CEO desks at hospitals around the country and insurance plans. And so if I can just simplify sort of like the vision here is we're going to combine the ROI and the great health outcomes data from Nurse Disrupted with the self-reported data from Catholic Charities, and that means our case managers asking homeless individuals, how many times did you use the ER, before you were housed when you're living on the street compared to after you move in? So we have the Nurse Disrupted data, we have our self-reported client data that the case managers are really grinding away and capturing. Then we have the hospital data from some of the hospital systems who have said, hey, we're going to give you that data and actually, give some of our de-identified data to match what Nurse Disrupted and you all have put together. And I say all this because we have now those three parties, Nurse Disrupted, the hospital system, Catholic Charities, all showing an ROI. And guess what? And who is this for in the end over the next couple of years, who we're going to make the case to are going to be insurance companies who are in the pockets of, and they're the plans that the homeless individuals are attached to. And so we believe this is all, as we're improving health outcomes in the right way and bringing access to healthcare services into the community and going towards the client, which I think is the future and the wave here. We have to break into the communities. As we're doing that with the right vision, we're also not naive to the fact that, hey, we've got to form a case all together collectively to make a case to, the insurance industry, which profited, I think around, I want to say $40 billion last year. So
is that right?
there's money there.
Yeah. I think that, the Beacon is a Catholic Charities day resource for people experiencing homelessness here in Madison, Wisconsin, where we are. And they did a bang up job with a pilot program with a pair. And the pair is so excited. It was a performance improvement project. It was mental health services for just a little slice of time at the Beacon. The staff of the Beacon was awesome, Ben, that. But just the little bit of therapy was there. Again, that ROI is low hanging fruit. I'm also looking at, these numbers you throw out are extraordinary. And all we've seen is our homeless populations grow. I was talking to our mayor, a couple months ago, and I think she said something like our homelessness, I don't want to misquote this, it's something like 200 or 400% increase. Do you know what that said? Because it's a nationwide increase, just
Wow.
housing instability. People have been flipping over, and we're just seeing our shelters busting at the seams. The occupancy is so massive. So the economics of it and the pressures that we've seen are only increasing. We've
Intensifying.
really got to get this across the finish line. Yeah.
Yeah, no, it's a serious problem. I mean, to your point, though, I feel extremely optimistic that we'll solve homelessness in our lifetimes because of the fact that the money's there. We just have to
That's a big
figure
statement.
out,
Yeah.
we just have to figure out ways, creative ways to create new models that probably don't even exist right now that is going to solve homelessness. And I think we've been doing these homeless forums around the country, and we were just in Oakland and listening to the leaders there and the government officials. And what really hit me is we can't wait for the government to give us some sort of panacea that's going to solve homelessness.
Right.
And I think we've been waiting for that for a while and being optimistic. And, that doesn't seem to be coming. And so I think where we're at now is, and sort of taking a page out of your creativity, Bree, and like where we're at is, hey, we can't wait for the government. So we have to create practical, creative models that we can pilot potentially with the government, and in the meantime capture meaningful data and cost savings and ROI. And I think if we can present models to HUD and other, intra-agency of homelessness within the government and these other government entities that have their eye on this problem, I really think, maybe it's not the Nurse Disrupted and Catholic Charities USA collaboration that, is like help solve it, although I hope it is a piece of it. But maybe it's
Yeah.
somebody down the line that sees literature or a study that we did together that says, wow, that's a good idea. Let me take that. And so I think just even if we aren't and I always think to myself and sort of like with our team, like, why not us? Why can't we be,
Right.
why can't we be the creativity that solves this? Because really it's going to take creativity to solve it. And we have
Yeah.
to start somewhere and we have to be different about the way we present data. And I think, Bree, what you're doing with Nurse Disrupted, and you've heard me say this so much. I mean, I just appreciate the practicality mixed with the creativity and then emphasis on the data while you're moving with the right mission. And if we can present pilots like this to the government to say, hey, when you collaborate together, it's powerful. And not only is it powerful, but it creates cost savings, which
Yeah,
everybody
it
loves.
works.
And we have to reroute that money back into services and into housing.
I think so too. And something I love about working with you is your passion in this space. We're doing things that haven't been done before. The data, there's been an absence of data. I mean, the databases are disparate. There's state homelessness databases, the Medicaid databases, state by state, the healthcare databases that need to be matched up, but we're able to pull this information together. But there's another thing, Ben, in working with you is your drive and your passion and your belief that there can
Yeah.
be a better today. I mean, hearing you say that you think in our lifetimes that this is solvable and pretty
Yeah.
much a why not us thing is incredible. So I mean, I've got to ask you why this space? I mean, you can hear your passion, your drive, and you're pulling the stars into a line. What drives you in this?
Yeah, no, I mean it all goes back, I mean, to the my mentor early on, Dr. Rigamer, who's just a brilliant psychiatrist. He's 80 years old, still practicing in New Orleans, one of the few psychiatrists taking Medicaid, helping the Medicaid population in New Orleans. And when I first started, I mean, all the stuff that I'm regurgitating, it was all taught to me from him. And he always said, Ben, we can start better. I can start a better healthcare program under the umbrella of Catholic Charities, under the social service umbrella, than I can out of the actual hospital walls. And so we'll start with social services and the healthcare program there, and then we can link people into healthcare. And I saw this really amazing collaboration when I was in New Orleans between the emergency room and the homeless really in that emergency room, and then what was following the homeless after they got out of the ER into the community. And really, I just saw that it was solvable. It's a lack of resources and it's a lack of health services and resources on really that ground level that's connecting people. And so I think really a lot of resources being channeled and funneled, if we can make the case with the right data to get more money, more of a financial push to that ground level for those caseworkers and to really get people linked in. I really believe, and from what I saw in New Orleans, we opened up the largest homeless housing project in New Orleans. And one of the first things we did when people moved in is we said, what healthcare are you linked to? What clinic in the city are you linked
Right.
to? It was really the staple of our case management. And just seeing that combination of, housing is health, which I really believe.
Yeah.
But then there's also hey, this person that was living on the street, and we know this because of the emergency room data and the hospital data that we had on a micro level, their costs were astronomical before they got into housing. And now not
Right.
only are they getting into housing, but they're receiving healthcare services, they're receiving case management services, and possibly for the rest of their life. So the ROI on what someone costs when they were homeless, and I was sitting in a meeting with one of the medical directors of one of the Medicaid plans in Louisiana at one point, and I'll never forget, and this lit my mind up on fire. She said, a super utilizer, somebody who's sick and uses the emergency room all the time, costs
Yeah.
our plan, $60,000 a year. And you start
Yeah.
doing the math on $60,000 a year for a homeless person you see who's unnecessarily using the healthcare system. 50 people times 60,000 is a $3 million problem for every 50 homeless people you see on the street. You're telling me that with $3 million, what we could do? So the
Right.
money's there, and that's why I'm just so hopeful. I know it's going to be solved. We just have to create different models and stay creative and reroute some of this funding to the right areas.
And that's totally right in that this is not a financial pit. It's not an endless investment. There is a return on the investment and a period by which the tide is changed in regards to the appropriate utilization of healthcare, the appropriate access to it. So, you know, it's not that there needs to be endless money. People who are experiencing homelessness that do receive housing and healthcare stability are able to transition from homelessness to stable housing, and the investment really works out in the end. And we're going to keep pushing forward. I'm so excited about the data and analytics that we've been able to gather. Really excited about working together to continue to put this in front of payers and health systems. And I'm so honored to know you and to be working with you. And I'm so glad I got to catch up with you today.
Yeah, thanks so much, Brie. I always love talking. And keep the think tank creativity alive, because it's going to be through these conversations that the homeless situation is solved. I really believe it. So thanks for your great mind on this.
Wonderful. Thanks, Ben. We'll talk to you soon.
Okay, bye.